Elizabeth Ford. I was on your panel last week, which was amazing for social determinants of health. Happy to be in the moderator position this time. And we have an amazing panel today. Before we get started, though, I would be remiss if I didn't send up prayers for both North Carolina and Florida for the incoming hurricane and the hurricane that just blew through. We are praying for everyone's safety. We know that while this topic is important, human life and safety are more important. So we want to make sure that everybody who's not able to attend because they're preparing for the hurricane knows that they are in our thoughts. To that end, I want to let you know that Dr. Elizabeth Cuervo Tilson, who was planning to attend today, is obviously managing North Carolina storm issues. Currently, she is the state health director. And so we're very lucky to have in her stead Maria Perez, who is the associate director of Healthy Opportunities in North Carolina. And it's a pilot program. It's the nation's first comprehensive program to test and evaluate the impact of providing selective evidence-based non-medical interventions related to housing, food, transportation, and interpersonal safety and toxic stress to high needs Medicaid enrollees through an 1115 waiver. Maria holds an MPH in health policy from UNC Gilling School of Global Public Health. And so I'm very excited that she's going to be here to speak with us. We also have Alana Kalinowski, who is the Director of Interoperability and Collective Impact for 211 CIE San Diego, and you'll learn more about what that is all about. She's also a founding leader of the San Diego Community Information Exchange, which is what CIE stands for, leveraging her expansive understanding of San Diego's system-level health and social service landscape. She leads CIE system interoperability and data integration projects, which we know from the last session is super important. She also works with a number of sector-based and cross-sector collaboratives to support system-level collective impact and strategic use of CIE as infrastructure and as a data source to achieve collaborative goals. So you'll hear more from her shortly. And then certainly last but not least, we have Alissa Glenn, who serves as Director of Community Health and Nutrition at the Greater Cleveland Food Bank. Alissa serves the food bank's work at the intersection of food and health, which we all know is critical, including building partnerships with healthcare providers and managed care organizations. She leads research on the effect of food interventions on insecure populations. She also oversees nutrition education initiatives. Alissa currently is pursuing her PhD in urban policy with a research focus on food policy. How much longer do you have to go, Alissa?
I just have to finish my research. I'm ABD.
That's awesome. Well, congratulations on that. So welcome this amazing Girl Power panel. First of all, very excited to have you all here. And I will let Maria get started if she's ready to give her 5-minute presentation, and we can go from there. Thank you.
Hello, everyone. And I can give just kind of a high-level overview of the types of SDOH work that we're doing in North Carolina. Try to give some semblance of what Dr. Tilson would have provided, but really excited to be able to speak with you all. So North Carolina, over the course of the last 8 years now, has really been trying to focus on this concept of buying health. We, in 2017, really started to work with our legislature on the idea of transitioning to Medicaid managed care. And within that, wanted to really think about how we did that really intentionally and thoughtfully. For anyone that's in the Medicaid space, you may be familiar with, that is a huge systems change that a state takes on to transition from fee-for-service to managed care. And we wanted to do it in a way that was really thoughtful to how we could really responsibly address the needs of members, our Medicaid members. And so we thought about, let's not just pay for healthcare costs, which we know are very high, but how can we address healthcare overall? And that was done through a Healthy Opportunities initiative overall. So just thinking about how we can address social drivers of health across the state, regardless of payer, how we could set up that infrastructure. And then how we could embed that infrastructure into Medicaid managed care to specifically address the needs of Medicaid beneficiaries. And that is where my work comes in with the Healthy Opportunities pilot. where we essentially take a lot of the infrastructure that is created statewide. So that includes a closed loop statewide referral platform, which we refer to as NC Care 360. There are other states that are leveraging similar technologies. I think we're all trying to figure out what is the best way to be able to refer people to where they need to go, and how can we make sure that providers know what happens to that person, right? So that they're not just kind of sending them into the void, but they can really know this person had a food need and it was addressed. So we utilized that closed loop referral platform. We also created a new payment infrastructure. So we developed a fee schedule, which defines and prices 29 services across the food, housing, transportation, and interpersonal safety and toxic stress domains. We launched 28 of them. The 29th happened to be a service that we could provide through a different authority. So we thought, it's complicated enough to stand up 28 services. Let's not worry about that 29th. But there are 28 services that we were able to begin providing across 33 counties in North Carolina. For anyone familiar with the state, that is a third of our counties. I do want to just kind of acknowledge and take a quick pause to acknowledge that 18 of those counties are in Western North Carolina, and so they are significantly impacted under the recent hurricane. But those, it's 3 regions, 33 counties, and within those counties, there are network leads, which are hub entities that contract with community-based organizations who are food pantries, shelters, transportation providers that deliver these 28 services across the region to eligible beneficiaries or members. And these high needs members are defined, in based on our agreement with CMS under our authority. We define high need based on clinical need and social need. So looking forward to sharing a little bit more around kind of what that program looks like, but at a really high level, what we are doing with the Healthy Opportunities Pilot is trying to bridge together this very clinical space of Medicaid managed care, where health plans that may be national entities are really familiar with having one kind of point and click. You have one service is reimbursed exactly as it is, very clearly defined. And social supports, which are a little bit more nebulous and a little bit more where we're focusing on how do we wrap around the totality of a person's needs and not just say, well, this person has diabetes and therefore they need X number of food boxes, but really think about, well, this person is food insecure. And how do we address that food insecurity? And over the course of that food insecurity, do we also discover that they may have other social care needs, which may be impacting the totality of their healthcare needs? So, happy to speak more to that as we go. Back to you, Dr. Ford.
Awesome. Thanks so much. I have lots of questions for you too, so we'll see what the audience comes up with. Next, we'll ask Alana Kalinowski to provide her remarks. Thanks.
Hi, everyone. Alana here, grateful to be here and kind of share this space. So I'm, as Dr. Ford mentioned, I'm part of 211 in San Diego, but I'm also kind of been a part of all stages of our community information exchange kind of development and wearing different hats. And so many of you may be already familiar with 211s. They're kind of across the country, and their main, kind of mission is to be this community resource hub of what is out of in a community and available for people. When people say, wouldn't it be great if there was one place people could go to find resources that are available? That's kind of what a 211 is. And they often have call centers and do other types of work. But it's really also to make known and collated all of the types of services that exist. So that's kind of the 211 side of life. The CIE side of life, or the Community Information Exchange, which I'm a part of and lead interoperability with, there's CIEs all over the country. It's been kind of this exciting movement. And really what CIE is this attempt to knit together very disparate systems of care into a cohesive way of bringing the system infrastructurally together. So our CIE, we talk about it as it is both this legal network of health and social service agencies in San Diego that enables the ability to share data and information for people who have opted in to give their consent to say, yes, help me coordinate my care and take the burden of coordination off of patients and clients, which is traditionally how our systems have been set up. And how do we actually make the systems talk to each other, and enable that more holistic care coordination where you get to build off of people's experiences, what they're telling you they've tried, what they want to, what kinds of supports they're seeking, and also the ability to have different parts of their intersectional identity be meaningful when it needs to be meaningful when it comes to access. And so our CIE is this legal network of health and social services that is able to pull information across systems into one kind of master longitudinal record that both gets to capture the diversity of social data that is necessary to kind of treat and address needs related to really complex realities of people's lives, that of course also intersects with healthcare. And where, you know, a health information exchange might be about the ability to exchange very, you know, kind of clinical data around, you know, labs and test results and things like that to make that continuity of care happen. The CIE is what data really must be exchanged so that someone's able to not only know what's out in the community that can meet the need I have, but meet the need because of who I am specifically. And that really reflects also kind of the nature of social services. You know, social services, it's not just that they say, hey, we're trying to make sure you can get to this this education program and I offer transportation or childcare. It's I'm funded to provide that service, but because of the nature of my funding structures, I'm able to serve, you know, people with 138 FPL who live in this zip code, who are documented disabled and employed and have children under the age of 5, or whatever the eligibility criteria is, which can be really complex and difficult to navigate. And that's part of why the CIE is meant to hold together this really diverse system of care that is represented by social services and bring it into a more kind of cohesive space that gets to be, you know, leveraged as infrastructure and be this shared space that we can, as providers, come together and work together in a more meaningful way. So I will stop there, and the CIE, I will just say what's cool about it and what I get to do is when you talk about infrastructure and an infrastructure that enables systems of care to come together, it gets to be used in really cool ways. And that's part of what I really enjoy about some of the work we get to do, both with our California's Medicaid waiver of CalAIM. I also get to do a lot of work with the Gravity Project in creating SDOH data standards that are going to further enable that interoperability between systems. And how do we try and thread the needle between capturing data standards that really are wildly diverse data sets that reflect the complexity of our lives. So anyway, glad to be here.
Awesome, thank you. Alana, not Alana. My apologies. Let me remind the viewers that you can submit your questions in the chat and we will get to as many as we can after the presentations, and whatever we don't get to online, they will have responses available for you next week. Thanks. Next, we have Alissa Glenn. Welcome.
Thank you so much. Thanks for having me today. I'm already hearing so many of the issues that I think about on a daily basis, so I feel like I'm in very good company here. My name is Alissa Glenn, and I serve as the Director of Community Health, Nutrition, and Measurement at the Greater Cleveland Food Bank. In this role, I oversee all of our healthcare partnerships, our community nutrition initiatives, and our research and evaluation work. And I've been in this space for about 6 years, and I've seen the landscape for this intersection of healthcare and SDOH expand and develop, I think, an incredible amount. When I started, we had genuine interest from our local health systems to form partnerships, and of course, interest on our part on improving health outcomes among those we serve in the community, but not a lot of understanding on either end as to how to work with each other to maximize our collective impact. So in the years since, we've come a very long way. We have at our food bank robust partnerships with 4 large hospital systems, as well as several FQHCs that serve Northeast Ohio. Our partnerships have resulted in hundreds of thousands of patients being screened for food insecurity, with many of those receiving referrals to food sources, either on site at their clinical provider or to our food bank for navigation to the various food sources in their communities, as well as support in applying for public benefits such as SNAP, Medicaid, and TANF, and connections to other community partners as needed. We have also launched new and innovative programs such as Nourishing Beginnings, which is a pilot program and research project that provides home-delivered, medically tailored groceries to low-income pregnant people in Cuyahoga County, where we have the unfortunate distinction of deeply inequitable and entrenched disparities in birth and maternal health outcomes by race. So I have seen our local health systems invest significant time and energy in this work. More than one hospital system has undergone some reorganization, creating physicians and organizational structures to fully support addressing social drivers of health, investing in electronic referral platforms to connect those with identified needs to community resources, and expanding their own abilities to provide food on-site in underserved communities. At the food bank, we have also made investments, hiring staff to support the work of receiving and processing referrals, managing healthcare partnership programs, and investing in research that can demonstrate improved health outcomes and associated cost savings to the system. So we are highly motivated, we are highly invested, and we are starting to see positive outcomes. But we do not yet have sustainable footing. We are primarily fundraising to support the development of these initiatives. So we need more research that demonstrates what is working, defining the programs and models that are most effective, and very importantly, outlining where the cost savings emerge so that we can work to advance policy such as 1115 waivers that cement effective programs and make them available to everyone who can benefit from them.
Awesome. Thank you so much. That work is so powerful. I want to continue with you, Alissa, for a minute. So tell us about the changes you've seen at the Greater Cleveland Food Bank since you've integrated with medical providers. Because one of the things we spoke of last week is this need, to your point about we're trying to have sustainability, proving that this actually does benefit and it has positive outcomes, not only from the well-being perspective, but are there financial savings as well? And if so, please let us know about that. Thanks.
Yeah, so well, the first thing I would say is that integrating with medical providers is not a binary situation. It's not a yes, no, at least not at the current state. It's really an evolving process. So when we started around 6 years ago, what we started with was really bringing medical providers into the services that we were already providing. And that was a low lift and something that was really beneficial for all of us, because as we expanded our programs to healthcare providers, we were able to work with them more closely and really learn how to speak each other's languages. And that's really very important because the language of health systems and medical providers is very different from the language of community-based organizations. So, those initial years were really just about learning about the incentives for the two different systems and where we could work together and understanding what all of our priorities were. So as we've gotten to work together more, we have more integration. For example, we currently are using Unite Us, an electronic referral system, to receive referrals from our healthcare systems. And we work with them on a very regular basis to kind of troubleshoot how those referrals are going. But that said, we are not fully integrated. So those referrals are still electronically separated from the systems that we're using to track access. And that's where, states like North Carolina, where they're working to fully integrate those systems, that's really the end goal. So I would say we're partially there.
Great, thank you. Alana, what's the most common challenge that you face when you're trying to integrate data through your various partners?
Yeah, so we've been fortunate enough to get to basically integrate with all different types of data. Hospitals, health plans, FQHCs, and then a number of CBOs. And I always this is my little soapbox that I always just kind of put into the world. In the world of interoperability, there's often this myth and misnomer that CBOs do not have the technical sophistication to be interoperable. And I just want to note that that's not a blanket true statement. And while some CBOs don't necessarily have the ability to tailor an API, That's not been our experience in our CIE. You know, as we kind of grew very organically within our community, it was the CBOs that were kind of the first to say, we already are doing care coordination. We're already working together in this like community of care providers, and our ability to build off each other and share what each other are doing benefits our clients, and we want to participate in that. And so we had the chance to be able to do that. I would say a lot of times the challenges we have is a couple things. There's, when I integrate data with different kinds of health entities, not a lot of health entities necessarily capture kind of really needed minimal data that you need to get a connective, successful closed loop referral for a social connection. So within our CIE, we have a lot of different types of care coordination activities, like a closed loop referral functionality. You also can see things like who's on a care team. They get alerts from, like, say, EMS and transports to the hospital. You can see what program someone's been enrolled in and things like that. And so in order to like make a meaningful connection and have someone from an EHR be able to make a referral to another entity, you need to have enough data around someone's situation. Namely, for instance, there is no service in town that you can access without knowing an income and household size, which calculates your AMI and FPL. Means testing is the name of every situation when it comes to access. And if that's not being captured and you want to have that successful closed loop, you kind of have to have that as part of your data payload. I'd also say like the ability to tailor APIs is really important. And also EHRs and entities that have writable APIs is wildly important, because it needs to be bi-directional for an interoperable system. Whether it's even just being able to push back like referral outcomes. What happened? Did they get this service? If not, why not? What happened? Right? And so I think a lot of the technology is there, but sometimes our workflows don't necessarily enable that. And also I think of how so often, you know, when you have, and this is where I think a lot of data standards work is going, but the ability to maintain kind of hierarchical data or relational or dependent data. So like, if I'm a client and I'm trying to get access to something, but I know I need to first get childcare before I can go to this employment program. The kind of interdependency of my real life experience of what I'm trying to access and how and when, that doesn't necessarily get to sit in the payload in a meaningful way, and it gets lost if it collapses into, say, a flat file or, you know, something else. And so, not to get too technical there, I think there's those kinds of ways that our actual data systems themselves don't capture the information about what is happening, and it's sometimes a little formulaic of, okay, you need this, here you go, and that's not the reality of like how people get things. And so I think having our systems reflect that complexity, but also not think that technology and interoperability is the solution. It enables care coordination and access, and even then that doesn't necessarily handle a situation of someone's need. So I think us making sure we're really recognizing that interoperability is essential for us to do things in a meaningful, collaborative way. And at the same time, it's also not going to solve our social ills.
Awesome, thank you. And I have a question actually for all of you. I'll get through this next round, but about platforms. But right now we're going to go back to Maria. So talk to us more about the 1115 waiver you have. How has it been working? What's being done in terms of integrating social drivers? You know, just give us kind of an update on how, first of all, how long have you had it, and what's it looking like so far?
Yeah, so North Carolina received its 1115 waiver authority in 2018. It went into effect in 2019. So we are in our 5th year, which for anyone familiar with 1115s, they are typically a 5-year period. So we are in the midst of negotiations for our renewal for an additional 5-year period. In a nutshell, if I had to give the elevator pitch, an 1115 waiver is essentially an authority that allows a state to operate differently from how Medicaid traditionally operates. So North Carolina, we utilized our 1115 in order to be able to transition to Medicaid managed care from a fee-for-service model. And we, within that transition, also saw that as an opportunity to build in a request to our federal partners to have authority to use a portion of that funding, up to $650 million, to provide these non-clinical supports, which would be included up to $100 million in infrastructure development funding, which we refer to as capacity building funding, which would allow community-based organizations, which, to Alana's earlier point, some organizations have a high degree of sophistication. They are fully able to not only advocate for themselves, but to develop the systems they need independently to be able to operate within the Medicaid infrastructure. But some organizations do not. And so we wanted to provide really equal footing in North Carolina and really focusing on empowering organizations within the state to be able to do this work of providing these different supports. And so capacity building funding was a significant portion of what we requested. The remaining funding, the $550 million that remained from our initial request, was really for service delivery. So that was being able to pay providers for the provision of food boxes and payment of first month's rent and security deposit and utilities and remediation, all of these different services being directly reimbursed. Now, different states use their 1115s in different ways. 1115s aren't kind of one blanket statement to say every state will do the same thing with it. Again, it's a waiver. It's a way to be able to test things out as a state. So in North Carolina, we have a very extensive evaluation that was a part of our 1115. And it's actually part of what allowed us to really stand up our work, is being able to say there is a significant evidence base saying that there are food needs and housing needs and transportation needs that, if addressed, if we can help people get to a gym after they've had some orthopedic surgery that they need to recover from, they will have better outcomes. If we are able to get people to a church, if they are experiencing social isolation, we expect that their outcomes will improve. And then there are also, I feel like there are some where the evidence base is greater for some things than for others. So for food, for example, fruit and vegetable prescriptions, that's an area where there's pretty extensive literature showing that there's a real benefit, a real healthcare benefit, a real cost benefit to being able to provide those services. So in North Carolina, we kind of pull all those together into these 29 services that are in our fee schedule that we are providing. And these services are essentially delivered through community-based organizations. The waiver, really what it allowed us to do is to develop the infrastructure and to have the authority to use funding. So it allowed us to, say to our health plans, our managed care organizations, you have to do this. You have to be a part of this pilot. You have to make these referrals to eligible individuals up to the capped amount, right? This is still a pilot. We have a budget. And it allowed us to stand up network lead entities, which are a brand new entity to how we are operating Medicaid. They've a similar concept of a care hub has existed in one shape or form or another, for example, in the aging space. But it allowed us to stand up network leads, which are our care hub model that allowed us to have a bridge between community-based organizations, which again, some may be highly sophisticated. They don't have as much need to have somebody kind of being a go-between with the health plans. But there are some organizations that we, sometimes refer to as the mom and pop shops that are really one or two people that have just, with whatever funding they can piece together, been providing resources to their community for as long as, they can remember. And we wanted to be able to empower all of these different organizations to feel like they could participate in this program meaningfully and be able to benefit from the reimbursement without displacing the work that they were already doing for their community more broadly. And so what the 1115 waiver does is it gives the state the authority to be able to plan out kind of what will this model look like. Let's make sure we have the authority to do this work. And then in North Carolina, we kind of took that model and then interpreted through, like, what does this actually look like on the ground? We have the authority to tell the health plans that they have to provide these services, but how do we make sure that they are reimbursing timely? How do we define timeliness? Like, there are all of the other bits and pieces that come with after you get that authority, what does it look like to actually get that off the ground?
Thank you. So I have a question for all of you. Do you have a sort of a feedback loop or a service improvement mechanism for people that are receiving services? How are we evaluating these initiatives? I'll start with Alissa.
Sure. Yeah, that's a very important part of everything that we do. So we're lucky that we have a pretty robust data and research team at our food bank. It's 3 full-time people. So really baked into our services is a fair amount of surveying to understand how people are receiving the services. And that's beneficial to, first of all, make sure that we're providing the right services and to allow us to improve them. But second of all, to understand the types of outcomes that we're having. So we do ask questions around, is this improving your health? Is this improving your overall financial situation? Are you able to afford other things in your daily life that you wouldn't otherwise? So that's, pretty much universally across the board. When we have people's information to be able to survey them, ask them questions, we're doing that.
I can jump in.
Sorry, Alana, I'm sorry, I'm pointing to you. Sorry.
It's the Zoom, So we have a couple different things. So our CIE, it's very community led, right? Our governance has a lot of different layers to how, when we talk about feedback loops or surveying or like input, we kind of try and get it from as many sources as possible, as well as from the data itself. So for instance, our CIE has our Community Voice Advisory Board that is getting input from service providers and individuals with lived experience on like, how is the CIE kind of like serving and enabling connection to services in the community? And we also have like our network partner, and we have an advisory committee. We have like kind of a lot of different governance structures to help how we structure our CIE. But then also in the data itself, like, so for instance, this comes up in some of the interoperability I've done kind of with healthcare, for instance. A lot of times when the data sets we have available to capture, did someone get the service they were looking for? The data sets aren't necessarily always able to capture community capacity, for instance. So like, does it exist in the first place? And if it exists, is it actually accessible? And maybe it exists and is accessible, but you have to actually go through, because it's housing the coordinated entry because of HUD realities, or, what's the pathway to it? And so what we have found, like in our CIE within our closed loop referral functionality, for instance, we do have data elements that get at, was it because it wasn't available, and kind of that wider community capacity, but that's not always data I'm able to share back. It's more on the individual level of, did they contact it? Did they not? Did they get it? Did they not? So I think how we think about our data actually also matters in that respect. And that's part of our feedback, because I will say, I think there's sometimes a misunderstanding at times of what a community even has to meet social needs, and the reality of a greater demand than supply is the reality of a lot of access. And that's why you have community navigators and healthcare workers who are trying to help people kind of go through the many layers of hoops to even get the things that do exist. And so I don't mean to be a downer in that. It's more just, we need to work within the system we have and build it up together.
No, it's reality. It's not a down. You're absolutely right. Maria, how are you all evaluating your improvement plans and feedback loops?
Yeah, so we, again, as I mentioned earlier, we have a formal evaluation, which was approved by CMS, and that included things like a rapid cycle assessment, a summative evaluation. That was modified because our pilot was supposed to start circa 2019, and some things happened along the way, as we all remember. And so we started later. So we actually modified our evaluation process based on just what was happening in real time, right? So we had a rapid cycle assessment, which was completed, which gave us a lot of really helpful feedback on our implementation process and what worked and what didn't. And then we actually just completed an interim evaluation, which went a little bit deeper. We had more data on people actually enrolling, and it looked at the first year and a half of referrals and started to show just incredibly promising results about, having $85 per member per month cost reduction for beneficiaries that are receiving these SDOH supports via the Healthy Opportunities pilots as compared to comparable populations that would be eligible in non-pilot counties. We saw reductions in ED utilization. We saw reductions in hospitalizations, and we also saw a reduction in overall need of SDOH supports for members that are receiving these types of services. So there's these formal evaluations, which give us, the backing of, there is an independent evaluator, which for North Carolina is the UNC Shep Center, that is conducting this evaluation and able to kind of complete this really robust assessment of all of the data we have available and give us all this really amazing, promising data. And then there's also the day-to-day real-time information that we need to just keep things up and running and make sure, we're able to support our partners. And that looks a little bit different. That looks like operational reports that we get on a quarterly basis. That looks like meetings that we have with our partners at least once a month. So we meet with health plans, we meet with network leads, we meet with care managers, and through the network leads, we get a lot of feedback from community-based organizations, which we refer to as human service organizations. So it's kind of more of a combination of these operational reports and just meeting with people, talking with people, sometimes going directly to community-based organizations' offices to get some of this feedback of what's working, what's not, how can we improve? Because when you're kind of in this innovation space, you have to be really flexible about how your policies operate, and be able to adjust.
Great, thank you so much. So you all three have programs that are doing very well, or successfully serving the community. So tell me, what are some of the important features and lessons you've learned that you would like to see in this landscape? Is it a policy thing? Is it funding? Is it incentive structures? What lessons are you learning? What would you like to see moving forward? And I'll start back with you, Maria. It's time.
There are so many lessons. I think one of the, I think you can break it down by domain and see different challenges that need to be addressed. For example, in the IPV space, we're, as Alana was talking about, there's all of this great work that's being done to be able to share data interoperably. But when you're talking about services in the IPV space, or in the interpersonal violence space, that's not really possible. Just for the safety of the members, you have to be so careful about what gets shared, who can view the data. And that really alters how you think about the care management model, which is based upon everyone having access to that person's case file so that all of the care can be really thoughtfully coordinated. And that doesn't work for IPV. You have to think a little bit more about how organizations can interact one-on-one, how you can really centralize that person's care within as few organizations as possible. So those are some of the things to think about, and like that component of SDOH that I just want to call out for folks, because it is its own complex area. And then more broadly, I think within broader SDOH work, there's also the work of trying to make sure that we don't over-medicalize the work that is being done. I think that is truly one of the biggest challenges that I find myself reminding myself and our team, like what are we answering this question from? What perspective are we answering this question from? Is it from the perspective of how do we make it easier to process a claim? Because processing a claim quickly and easily is something that is very easily answerable. We just make everybody get an API. We make them be able to have the systems they need to be able to submit a claim and understand what an 837 and an 835 are. And most I will say at this time in North Carolina, most community-based organizations do not have that capability. They may develop that capability with time. They may have interest in developing that capability with time. But in the interim, wanting to make sure that we have a process in place that, and in North Carolina, what we did is we built into the NC Care 360 platform, which is developed by Unite Us. So similar to what Alissa was referring to, the system that they're using. We built into that an invoicing process that converts our invoices into claims automatically, so that a community-based organization submits an invoice. They say we provided 10 food boxes. 10 food boxes times our fee schedule rate equals the amount that they invoice, and then that is a claim that the health plan fulfills. So just trying to think through, I think from our perspective, is trying to think through how do we try to think from the perspective of what will be most straightforward for community-based organization to be able to do the work that they do well, which is meeting the needs of a member, ensuring that they are able to meet the trust that they have built with their community, without putting them in a position where they have to medicalize their work in order to be able to provide the service.
Great, thank you. Alana.
Yeah, Maria, I so appreciate everything you just said, and yes to that.
I sent a heart up too.
Yeah, because I think like just to kind of add on to like the medicalization piece of it is like, I think sometimes there is the reality of social service funding is sure, things like reimbursement is a part of a funding stream, but when you're talking about the reality of braided funding, that is how program designs are structured within social services. I think a lot of times I'm in spaces where there's this perception that reimbursement is like kind of the magical solution that is basically creating all these services, when like that's not really how that works. And so I think like not only the medicalization of like kind of the use cases and the workflows that people envision sometimes, but also like, yeah, the data, what is collected about people. You know, in the world of data standards making, there's this ridgepole that you have to walk of, we have to agree on definition and talking about the same thing in order to like translate data across systems. But at the same time, if we're pruning away the nuance and complexity of our intersectional lives and our personhoods, there's danger in creating like this homogenous set of data about how to describe a person's nuanced situation. And I think that is also you know, because that's important. You know, it's, you know, yes, we all have bodies, but we all are interacting with this world in very different ways and have very different like access and resources and privileges. And so I think like a lot of times when I think about some of the, when I say what I'd love to see is, I think recognizing that it's a matter of bringing together two kind of systems of care, rather than just asking either healthcare to all of a sudden encompass this completely other space of access and services. That's not going to really be possible in any kind of way that is person-centered. And also at the same time, I think there is the reality that care coordination is already happening amongst social service providers, and we can build upon that, I think, as systems come together. But I think what I'd love to note and say I think we need a lot of is, structurally speaking, funding for a program design that includes care coordination is not the given, right? Like a lot of times it's a case manager going above and beyond their job description or their structured time. So I think baking in things like, how do our systems connect and talk to each other? And how do I link someone to a domain adjacent to me? And that's baked into my program design, which is, you know, a call to funders as well, thinking about funding happening in tandem, funding happening in kind of cohesion, and not just, here I'm going to like fund this and this and this, and recognize, no, we need to be all thinking about how we all are part of this web of connection of what's out there, because we're asking people to navigate that as individuals, right? And so, and I would also, alongside that, just say, I think as we think about what it is to address social drivers of health and need, we should be thinking about the fact that technology is a tool that we get to wield and tailor to our individual communities. And yes, there's a different, we want to be able to scale because that's important, but that is not the same thing as like a kind of a one-trick pony dream of one tool to solve it all. That's not how anything works. So I think if we're you know, kind of susceptible to that siren song, we miss out on how do we need to account for our community and scale within that context. So I'll stop there because also I get a little preachy, but and you know, and I'll just kind of say, I did see a question in the Q&A. for instance, in San Diego County, we have just a fundamental binational population. And the reality of also people being undocumented is a big part of how we have like, our ethics and policy work groups around how is data shared, who's a part of our inclusion of our network of this closed space. All of this is born from like, what are we responding to within our own community and setting up either safeguards or accounting for inclusion limitations that we need to set in place, because we need to make sure we are building for our whole system of care and not just for people who are documented or English speaking or straight or whatever. So I'll stop there.
And we're going to get to those questions shortly. I just want to give Alissa a chance to answer the question about learning, lessons learned, and things she'd like to see in the landscape.
Yeah, thank you. It's so hard to go and answer these questions when my brain is spinning with all the brilliant things that the rest of you are saying. But from my perspective in Ohio, lessons learned. First of all, the research is still really, really important, and we actually really do need more of it. So from a nutrition intervention perspective, you have a few different buckets of services emerging. You have medically tailored meals, you have medically tailored groceries, and you have produce prescriptions. And the research is really the most fleshed out with medically tailored meals, medically tailored groceries, and produce prescriptions. So there's some compelling research. It's really not that clear yet, like what programmatic models and delivery models and what patient populations benefit the most from those. So I think very strongly that we need more research there, because when it comes to getting fee-for-service reimbursements in Ohio, and with the lack of policy levers that we have, we're in a situation where if we want to get these services to the neighbors that we're serving, we need to be going to medical directors of MCOs and saying, here's the data, here's the savings, here's who's going to benefit the most. And we don't have good research for that yet. So then the second big learning is that the policy is going to be absolutely critical, because even with the data, so for example, for medically tailored meals, the data there really is very good. But even with that data, in the state of Ohio, we have 10 different food banks and 7 different MCOs. So without a policy lever that really expands the incentives to be able to provide those services, we have a factorial of negotiations happening. We have different food banks negotiating with different MCOs for different services, and it's just not consistent, and it's not going to be a scenario in which we can kind of standardize services and grow them sustainably. So the policy is going to be really critical to be able to do that, again, like sustainably, and to be able to standardize those services.
Great, thank you so much. So there's a question that popped up a few times in the chat. And this came up last week also, so I just want to put it out there once and for all. So it was about social determinants of health versus social drivers of health. Personally, I use determinants a lot just because it's habit, but I think in terms of just nomenclature, social drivers probably makes more sense, because we don't want to say that these are determining health, because there's so many other factors that determine health. And it makes it seem like if you are unhoused and there's no opportunity for you to be healthy, if this isn't a determinant, but it is something that drives health. And so I just wanted to run that by you all and see what your thoughts are on this social determinants versus social driver discussion. What do you think about that? Anybody can jump in.
I would add that there are more acronyms to come. There are health-related social needs, health-related resource needs. I think there are lots of different ways to put a name or a brand on this. In North Carolina, healthy opportunities comes from our interpretation of social drivers of need and trying to treat them as an opportunity to improve that person's health. So I think at the end of the day, I agree with the nomenclature of social drivers is more appropriate, and it takes more into consideration the ways in which we can influence and redirect the drivers that are impacting a population's health. But again, I think this is also dependent upon what you are attempting to address. As a person with a public health background, there's also there are bits and pieces of every single one of these different acronyms has a fundamentally different meaning, but are also used fairly interchangeably.
Thank you. Anyone else want to jump in?
I would just agree. I mean, I think you nailed it. The language always evolves, and to my understanding, the shift from determinists to drivers is really just acknowledging that even though something has influenced one's ability to be healthy, it's not set in stone, and there's no reason that we shouldn't try to make things better.
Awesome. Thank you.
I'll also just add, I also like drivers particularly because I think when I think about the data that we capture, it's like, how do we represent people's situations? And I think so often we in a system, we try and create like, if this, then this. And I like things that push us away from formulaic thinking, because when you think of like an ACEs score, for instance, just because you have 4+ doesn't mean these things are true about your life, right? They might be true about your risk, but it doesn't actually speak about the truth of your situation. And so anytime that we have language that underscores the nuance of people's lived experiences and that it is not this cookie cutter formula, I'm for that. So.
Awesome. Thank you so much. Okay, we have lots of questions here, and they're really great questions. So I want to try to get to as many as possible, which might be a task, but there was, let's see, I can just pick one. For Alissa, are people selected for your program based on certain health indicators or based on FPL or some other food insecurity indicator? How are you picking people for your program?
So we have multiple programs, of course, that we operate, and the requirements are going to be different. I don't know if this particular question had to do perhaps with Nourishing Beginnings, which is our medically tailored grocery program. And the criteria for that program are, it runs through our community care coordination hub, or our pathways hub model. So the reason to do that is that we were able to engage community health workers who are employed and reimbursed through the hub through a variety of different systems. So the requirements are therefore consistent with the requirements at the hub. So this means that to be eligible for that program, one needs to live in Cuyahoga County. They need to be on Medicaid or Medicaid eligible. And because it is a research study, one needs to be an adult and of course be pregnant. So that's the criteria for that program.
Thank you so much. This came from an attendee, but I had a similar question around capacity because, I think of all these referral things. From my perspective, I'm always worried that the system's going to be overburdened, and we've seen instances of that. And so this question is to Maria, but I think it may also apply to Alana to some extent. To date, how are the CBOs supported with these capacity building funds in North Carolina with the waiver? How are you measuring the number of closed referrals, and how is this reimbursement of the closed referrals going with the CBOs? And so the connection to that would be for you, Alana, how are you managing capacity? Because we know there's need, but we're also worried that when we're sending these referrals out, that these institutions or organizations have capacity to actually address them. So I'll start with Maria and let you respond.
Yeah, so I would start by saying there's an understanding of demand, but there's not good data about demand, which is one of the biggest challenges we ran into in North Carolina when we were trying to assess what is the capacity we need to build. Because there's not, we now have a standardized SDOH screening tool, which does this for food, housing, transportation, and an IPV. And we require that tool be utilized for every Medicaid beneficiary as part of their enrollment in managed care and at routine intervals. Even our ability to assess if that is being done is challenging because every managed care organization is using a different system. And so the ability to have that data to see what is the actual demand, what is the actual need on the ground that people have for food services versus transportation services, housing, or IPV is really, really challenging. I say that just to acknowledge that was one of our biggest challenges, and it continues to be one of our biggest challenges because we are learning demand in real time. We track referrals using the NC Care 360 platform, which is a closed loop referral platform. Essentially, the way we've set up the process is that a member is referred by their care manager who is either a part of the managed care organization's team, usually a social worker or a nurse, or they are a delegated entity of the health plan to complete that care management role. And that individual oversees that person's care plan. And as part of that care plan, they are referring them for food, housing, transportation, whatever they may need. The idea being that because they are doing that, they are also building trust with that person and able to identify if they call in and say, I need a food box, but along the way you learn, oh, because I'm able to pay for food, I no longer have the same challenge with my housing, but I haven't been able to get to work because my car broke down. And so I'm having to choose between how much, like, there's the cycle of like, what is actually creating the challenge. And so the idea being we're building that trust with the care manager or with the community-based organization who is providing the service and creating that kind of feedback loop between those entities within NCCare 360 and also more organically through email and phone call. So at the end of the day, what we're trying to do is say, like, how do we make sure that the community-based organizations that are providing these services have the staffing they need to be able to do this work, have the expertise they need to be able to do this work? And we can answer part of that with technology. By saying NCCare 360 is where you're getting your referrals. You won't have to worry about tracking how many referrals you get, or you do, but that's going to be tracked automatically through this platform because you're going to receive it. You're going to click that you received it. You're going to submit your invoice in the same platform. So all of that gets tracked in one system, and that makes things a little bit easier. But on the community-based organization side, there's still expertise that they need to develop. Organizations may also need seed funding in order to be able to, have the food materials that they need to be able to provide food boxes if they are providing to a greater population. One of the big challenges we run into as well is we're not trying to displace work that a community-based organization was already doing. We are trying to add a payer, not remove some of the work that they are doing. But that is something we have to consider as well, is just in increasing the demand on the work of this organization, are they able to staff up sufficiently that they are not having to turn away from work that they were already doing in their community?
That's my question. I'm sorry, does your waiver support staffing?
It does. So it supports staffing, it supports technology, training, technical assistance. These are broad terms. We are continuing to work with CMS to define them more explicitly or more clearly. But a lot of this comes down to really working closely with community-based organizations to assess how we can keep their work operating with the populations that they are already serving and just expanding upon that to allow them to serve greater populations. And the network leads themselves are also supported by capacity building to stand up initially. And that was really critical for the technical assistance and training components, because one thing that I've really learned along the way is, when you talk about a community-based organization, I think in some circles, we all kind of know who we're talking about. But sometimes when you're talking to community-based organizations, they think of themselves as a not-for-profit or as an academic institution or as a clinic. They don't think of themselves as a CBO. And so the network lead is really one of those entities that helps say, this is how you're thought of for this purpose. And this is how you develop a budget that really represents the actual cost of the work that you are doing, so that you can appropriately request the amount of capacity building funding that you need and appropriately measure if the amount that you are being reimbursed meets your funding needs.
Thank you. Did you want to add to that, Alana?
Yeah, I'll just briefly add a little bit to that. So yeah, I think because California, we did our waiver a little different than others as states go. So in San Diego, we do have like 4 plans. And, I think Maria brought up a lot of really solid points around kind of like the reality of if you're a CBO who is contracted to provide these community supports or enhanced case management, part of it is you also have to kind of have a certain level of administrative infrastructure in place to be able to do that. In part because there currently aren't standards around your payments, reporting, submission, remittance, all of those data standards, which as an aside, I got to work on within the Gravity Project, a discovery group to kind of get at understanding the nature and the consequences of there not being standardized data sets for submission and reimbursement and things like that. But so what we do locally is we host a lot of affinity groups, again, to Maria's point, like helping CBOs recognize like, okay, you all kind of are doing different things, but we kind of are a part of this dynamic that we're all trying to like respond to and be able to address and be able to essentially be reimbursed for. And it's a lot because there's you know, you have to go to different portals, you have to do different kinds of what documentation you need for submission can be different between the different plans. And that real cost, I think that's where the ability to capture that real cost is difficult. And then there's the capturing the real cost and capacity of those contracted providers. And then there's also the reality of like the availability just within the community. And that I think you know, we always talk about we value what we measure, and or what we can bill for. And I think as communities, you know, kind of coming together, elevating, how are we tracking what the extra pain points are for CBOs trying to do this submission? And like, so we have, for instance, with recuperative care beds, we came together as a community and identified like a eligibility screening tool that all the plans agreed to, and kind of with some like allows for some eligibility and bed assignment and submission, so that there's a little bit more streamlined agreement. And so I think that's also where like in our case as a CIE infrastructure, it's convenient and powerful to be able to be on kind of all sides of what is trying to happen, and being able to kind of facilitate some of that work as this shared space. Because I think those smaller orgs that don't have that administrative infrastructure can't absorb costs that isn't paid for. And there's an equity cost there as well. If you don't have these CBOs that are more grassroots or representing even further marginalized people and are able to participate in the reimbursement framework, and because their admin costs are too high, you are essentially now pushing further out and keeping that more mainstream CBO that is more funded and serves everybody reinforced into the payment pool. So I think if we don't structurally account for how are we lifting that admin cost off, we are going to further the equity divide.
I agree. Essential heart for that. Question for Alissa. Food cooperatives. What do you think about those? Do you consider them a viable solution for food insecurity?
Well, so there is some pretty robust local food policy movement work happening in Northeast Ohio that has worked on developing food cooperatives and trying to centralize the foods that's produced from local farmers. And I think that's very valuable work, and the local food policy and local food movements are critically important, and very tied in with food justice issues. I would say from the perspective of the Greater Cleveland Food Bank, which is an organization that serves 6 counties, we're not the ones who are super involved in that work, so I can't speak too much about it. But from our perspective, what has helped to really expand our own offerings of local food and food that's grown close to home is some of the great policy work that's been done through our state association to help to get us local food contracts. So we have contracts with Ohio farmers who are able to sell their surplus produce to us, so we're able to distribute that food. And then there are also some supports, again, that are provided through the state association to help us buy and purchase more hyper local food. So policies like that help us to kind of bring local food into the food sources that we're able to use.
Thank you. There was a question. So Maria, you mentioned the issues around privacy and security with victims of IPV. I want to ask Alana about undocumented folks. San Diego has a huge undocumented population. Yeah. Are you serving them? And if so, how are you protecting them from?
Yeah, exactly. You know, I will say, and on a very real level. You know, when we kind of were first launching our CIE in 2017, it was very much in the context of our community. We had a lot of our organizations talking about the fact that, you know, ICE was showing up at their schools, and the reality of such scary, destabilizing, you know, kind of what does it cost to share my information is not just a theoretical thing. And so, and I think that's true of like whether someone's, you know, documented status, but other data that is not, you know, in the healthcare divide, which also I'll just kind of note, I think sometimes when we talk about consent and data ownership, there is this a little bit, sometimes a little too narrow focus on healthcare versus not healthcare and HIPAA compliance, which all matters, but recognizing there's a lot of data that is highly sensitive that is not necessarily part of that kind of covered entity divide or not, right? So that is our, you know, sexual assault and IPV and a whole host of things that is, when we talk about trauma-informed care, it's like, how do we actually enable that to be real and not just lip service? So in our actual making of our CIE, that is exactly how we basically started creating our inclusion exclusion policies of who's even a part of this network. So 211 fortunately already has these you know, kind of connections to all the services in the community, regionally across populations, and had already kind of the relationships. And so when we brought our network together, we had meeting after meeting and kind of and engaging people on like, you all represent people who have had their information historically used against them. How are we going to build a system that is protective and uses that vulnerable information to their benefit? And so I will say that that has dictated who's a part of CIE and who we can share data with. And then also, I will just note that that's also where a lot of differences come in between an HIE and a CIE, right? A lot of the governance gets to be reflected in our community. So we don't, for instance, include any entities that can use CIE to prosecute. So that includes, for instance, you know, we have homeless outreach teams that partner with local police force that are doing homeless outreach. They're not a part of our system because they're not legally essentially protected from having what they have access to being part of prosecution. So there's a whole lot of things that, not to get into the weeds of policy, but it's exactly why we have our community voice that does a lot of like advisory board, which is both people with lived experience and represent communities that are disproportionately affected by oppression. Basically to have working groups, education workshops, like basically giving that feedback. And then we have our policy and ethics groups where we are tailoring our community information exchange to what our network of partners have said is, you know, they're comfortable with. Planned Parenthood for a long time was not part of the network because they were also aware of, we don't want our information about who's interacting with us to be used against someone in a negative or biased way. So it's complex, but yeah, that's exactly why our governance is so localized.
Thank you. So let's talk about data. Let's go back to data because data is really the king to link all of these things in one way or another. And all of you mentioned some type of referral system. I know you all, two of you are using Unite Us, but a referral system is only as effective as it is robust. If they're not being used, then it doesn't work. And so, but folks, including myself, have been struggling on the ideal, you know, platform. And so let's talk about what are the components? What are the components of a really strong data collection platform? Let's go from there. So whoever wants to jump in.
Well, from a CBO perspective, I would say the more integrated, the better, because you're going to reduce duplicative efforts. And that is one of the issues that we have currently. You know, Unite Us and these electronic referral platforms, they're kind of like telephones. I think somebody in the question said, well, like, what if the CBOs aren't on there? And that's exactly right. If somebody doesn't pick up the phone doesn't provide a whole lot of value. And so, this is why the policy is important, because we have essentially a full-time staff person managing those referrals, and there is no policy for any type of reimbursement for that. And that is one of the struggles, is trying to get more people to use the system. But I understand very much people's reluctance to use it because we aren't getting reimbursements. And then when we are providing services to the people for whom we get these referrals, there is duplicative effort to enter them into our own systems to then provide those services. So, they're a good place to start, but if you can get to an end game where there are APIs and they can integrate into our systems, and then that goes fully all the way through to services provided and reimbursements for those services, that's what I would consider truly closed loop. And that really should be the end game. And I would just note, like, when you hear that closed loop referral, people don't always use the same definition for closed loop. So it's good to clarify.
Anyone else want to chime in?
So this is I'm actually next week at the Civitas conference. I'll be there with Paul Sorensen from Missouri. If anyone's going to be there, come say hi. We talk about this a lot because I think technology features, the ability to, the data that you capture, the APIs, your ability to tailor your APIs is basically what makes you whether you're interoperable or not. But really, your platform's ability to be tailored to what is the data that needs to be collected for your community, I think is such an important key. And so I think there is a base of data that is kind of everybody needs, right? From a eligibility perspective and enrollment and all those kinds of things. But I think platforms that are genuine tools that can be wielded to capture and meet the needs and meet the prioritizations of a community is really some of the core features. Because I think like a lot of the functions of what you do kind of flow from that. But if you can't, for instance, medical records are typically patient-oriented. A lot of CBOs have family-oriented records, or at least have the ability to make more complex targets of intervention within their client record. The ability to tailor some of how that data is structured to make more continuity of care and be able to like maintain messaging structure is like really important, right? And so I think any platform that is really good at being interoperable is one that takes the shape of the community it's serving. It's a generic answer, but that's kind of the core features I see.
Thank you. Oh, go ahead. Sorry.
All right. The one thing I wanted to add to this, and just completely agree on the interoperability piece, but the one thing I wanted to add is I think also coming from the perspective that and this has been said, but like the technology is the tool. So you do not necessarily need to say one tool needs to solve for every single need that we have. Sometimes it is you have multiple tools that need to be utilized, and you need all of those tools to be interoperable so that you can have all of the data that you need in one place. So I think that's more so just like a summary of what others are speaking to here, but I'll also give the example of like we're in North Carolina in the midst of disaster response. And I had a call earlier today with some folks in the housing space, and they were talking about how the types of data that they're able to view from FEMA sources, from HUD sources, and how they can bring all of that together. And I was thinking, well, I'm on the Medicaid side. And we famously do not have our data talk to each other very well. And so just trying to think through as well, there is getting Medicaid data and housing data to talk to each other, data that is structured in a household, from a household perspective, with data that is structured from an individual perspective, because Medicaid is driven by you are member A, you are getting these services. It's actually really hard to figure out, like, in this household of Medicaid people, who is getting what. And it's just a very different way of thinking. I will say for me, it's been a very different way of thinking of like, how do within different domains of work, how do they think about and view their data? And then start having that conversation of like, what are the pieces that matter to us most, to have those pieces come together first? Because we all need different things. We all need different tools because we're doing different work. our missions and our goals are a little bit different. Housing is trying to ensure that, people are housed and secure, and we are trying to ensure that people are healthy. And those things should work together, but they are still slightly different. And so just, again, acknowledging that looks a little bit different for everyone in the different work that they're doing, but keeping that in mind.
Thank you. Thank you for that add-on. So I wanted to throw in one last question, but I think we're out of time. Yeah, we are out of time. So thank you all for your time and attention today. Systems for Action. What a great panel. You all have a lot of questions you're going to have to answer offline because people are very interested in your work. And just want to thank you all for your time today. Again, thoughts and prayers to those in the line of the hurricane that passed and the hurricane that's coming. Everyone stay safe and have a great rest of your week. Thanks so much.